So, good morning, ladies and gentlemen. We're gathered here today when the world is facing significant challenges in strengthening and sustaining the health workforce. Mobility, competency assurance, and global alignment are no longer optional. They are the foundation of a resilient and responsive health ecosystem. Our discussion today will explore how regulators, accrediting bodies, and academic leaders can collaborate to enable health workforce that is competent and ready for the future. To start off our session, and in light to what we just heard from Mr. Jim Campbell, with the projection of 11 million healthcare worker shortage by 2030. I want to ask the panel what global partnerships or governance models can best address workforce gaps and support mobility in this challenging landscape. And if I may put you on the spot, Dr. Chaudhary, I would like to start with you.
Well, thank you very much, Dina. Assalamu alaikum wa rahmatullahi wa barakatuhu. I think it's important to know, as Jim pointed out, almost every country in the world is suffering a shortage of healthcare workers. It's important when you have that sort of situation to have trust among the medical regulators as well, meaning trust in the data about physicians to enable mobility. If we're talking about mobility of physicians, nurses, and others from one country to another, for example, it's important to have information about where they went to medical school or nursing school, where they trained, what are their qualifications, and more importantly, if there's been any history of a disciplinary matter. Because I think all that information enables us to begin to address some of these workforce shortages. In the United States, for example, we have 350 million people, and the number of physicians we have is a little over 1 million, and the number of nurses is almost 6 million. Now, those numbers seem very large, but there's a wide geographic disparity in terms of both primary care physicians and specialists to be able to serve the needs of a growing and aging population. So I think organizations like mine, like the Federation of State Medical Boards, which oversees licensing and regulation, partnering with organizations like IAMRA, the International Association of Medical Regulatory Authorities, of which the Saudi Commission is a member and a board member, enables the sharing of data and information to begin to address these issues.
Thank you, Dr. Chaudhary, and it really underscores how trust and data transparency is very important as the backbone for workforce mobility. If I move next to Dr. Giddens, what do you think, if I ask you the same question, what partnerships or governance models would help with this gap?
Thank you, and good morning. I think it's not just the size of the shortfall, but it's also the imbalance in where those healthcare workers are trained and retained and recognized. So there's not a global one-size-fits-all model. But what has been shown to be effective are partnerships that are based in mutual accountability. So where you have countries that invest in both their education systems as well as in fair and ethical recruitment. Perhaps Dr. Chaudhary is better positioned to speak to this than I am, but from the North American vantage point, regional and professional compacts, especially those that are anchored in shared competencies and in transparent accreditation, have shown promise. So the goal is to enable health workforce mobility while strengthening and not draining capacity in all sectors. So governance models that are transparent, that are data-driven, and that are equity-informed, I believe are the ones that lead to the greatest global benefit.
Thank you, Gordon. So you brought up a great point about stressing the transparency of the data and the mutual accountability of both parties in these partnerships. I would like to ask the same question to Renee, please. What are your thoughts?
Salam alaikum. I feel that I bring a different perspective from being an accreditation body. We look at some of the integration. I'm in medical travel and wellness travel. So we look at the integration of sectors. When we're talking about a health care shortage or health personnel shortage, the impact of filling that shortage is $1.1 trillion, saving over 100 million lives from unnecessary death and disability. So we have to personalize this reality of the gap and say, how can we most logically fill it? The intersection between health and hospitality, for example, presents a fabulous opportunity to cross-train, bringing hospitality personnel into healthcare, bringing healthcare personnel into hospitality to fulfill the 49 million hospitality personnel that will be lacking by 2035. So data is important for tracking, but accreditation provides an opportunity to standardize, to cross-train, not just the organizations, but the personnel, and to mobilize that personnel to different parts of the world where they can best be leveraged for their experience. So cultural competency, patient experience, hospitality, consumer, customer, guest experience, all of these areas are becoming more prominent at this intersection between health and hospitality. And that requires collaboration in these sectors. So I think what we're seeing now in the kingdom, where there's an investment in all sectors, that's an environment for the ability to become a global hub in this intersection point. So no longer looking at it as standalone industries that are addressed separately, but really bringing accreditation and certification and cross-training and partnerships to feed off of and invest at this intersection point.
So a great point, so having that wider scope and a wider perspective. Thank you. David, question for you from your perspective as a clinician. How can global health systems collaborate to expand international training and fellowship pathways that strengthen the global capacity and the needs?
Thank you for that question, and truly an honor to be here and part of this remarkable programming. Ultimately, we need to accomplish an opportunity that addresses this major shortfall that is both an economic and security issue as well. It's not just a health issue. And we need to think about that in depth when we're thinking about policies and endeavors to improve the lives of those around us and improve the educational mission of those around us. As Renee touched upon, if we address this workforce shortage, we have an opportunity to decrease disease burden by up to 7% and add $1 trillion to the economies that we serve. That's remarkable opportunity there, and it's an opportunity that we need to take. To expand on the question that was asked specifically around training, we need to accomplish this using two things. More advanced specialist training that is truly global in nature and not just intermittently watching a video or engaging at a conference, but making it a true initiative where that the exchange of ideas also matches the exchange of expertise and allows for free flow of persons back and forth. And then we need to leverage technology to bring that to scale. So through private and public and academic affiliations, we can rethink how we mobilize the workforce globally. So for example, instead of having observerships that last maybe 1 or 2 weeks at a time, we can formulate and develop more robust exchange programs where surgeons and non-surgeons travel and have relationships between one institution and another. And maybe that lasts 1 month, but with the use of technology, we can now exchange ideas better. We can bring people into the operating room with us through virtual reality and AI. Following that, we can then hold joint case conferences We can have this whole robust exchange program that outlives what has historically been a 1 or 2 week endeavor at one of our esteemed institutions in the United States, an esteemed institution in the Kingdom, for example. So via these types of rethinking how we optimize technology to deliver better educational experiences, utilizing the work that my colleagues on the stage are doing as well from a licensing and educational perspective, we can really take the step forward in creating long-lasting relationships that drive to the real crux of the matter, which is understanding that all of us around the world must have access to high-quality care, and that exchanging ideas is no longer sufficient, but exchanging personnel consistently and thoroughly to make sure that all competencies are the same and standardized can lead to real change both in the Kingdom, in the United States, and in countries everywhere.
Thank you very much. Great insight. So leveraging technology to share expertise, share knowledge, and to expand the capacity of the healthcare workforce. Dr. Chaudhary, I would like to ask you in your role in IAMRA, how do you envision integrating emerging technologies such as AI, data analytics, and medical regulatory frameworks to improve competency assessment, support the continuous education, and facilitate workers' mobilities?
Thank you very much, Dina, and I'm so glad that my colleagues and David talked about the role of technology, because as we deal with the issues that Jim spoke about in terms of what's happening globally, I think technology is an opportunity to harness something that makes a difference. Not necessarily replace, obviously, the healthcare practitioners we need, but augment that. And so IAMRA, the International Association of Medical Regulatory Authorities, just held its 16th meeting in Dublin, Ireland, sponsored by the Medical Council of Ireland. And at that meeting, actually, the Saudi Commission for Healthcare Specialists proposed to the world body that there should be a framework, a global framework for medical regulators like the organization I represent and the world to come together to put together a policy related to artificial intelligence. And that was passed by IAMRA. So one of the things we're going to be working on as medical regulators is to figure out how we can use data to predict where shortages will be dire, where they need our assistance the most, whether it's specialties or primary care, different regions within countries and also around the world. One of the great things about meetings like this, and I give a lot of credit to the Kingdom for their Vision 2030, is that while it benefits the Kingdom, it also benefits all of us in networking and collaborating. I'll just give you two quick examples. In visiting the booth for the Saudi Commission, we learned how they have an AI hub, which is about 6 months old. So it's very nascent, but it is planning to do more with data to make a difference. In the United States, the Federation of State Medical Boards also has an Office of AI Innovation, which also happens to be 6 months old. And we've been working independently. I think there are some opportunities to come together. Same thing with the licensing exam. The Saudi medical licensing exam is known throughout the MENA region. Our licensing exam, the US medical licensing examination, is also known worldwide. And we've been working independently for years. I think there are opportunities for collaboration there as well.
Well, it seems that IAMRA is leading now the efforts for the AI in healthcare to be used safely. And we're happy we had a role in that. I want to go back to Dr. Gordon and ask you about, from your regulatory perspective, how can regulators collaborate to build mutual recognition and harmonize cross-border credentialing frameworks that enable mobility to maintain quality and safety in the healthcare sector?
Thanks, that's a great question. I think first by acknowledging that collaboration will never be unification. So every jurisdiction has its own legislation, its own government support, its own political climate. So healthcare worker mobility is about far more than just the license. Speaking from the perspective of Alberta, we have undergone a little bit of a paradigm shift recently. It used to be that if you wanted to come to Alberta to practice, we would look to see that you had your 4 years of medical school, your 5 years of postgraduate training, or 2 years if you're in family medicine. We've come to realize that that's just not the way the world works, and that training can be structured in many different ways and still produce quite excellent practitioners. And this is one of the things that informed a new initiative that we've undertaken at the College of Physicians and Surgeons, which is called the Approved Jurisdictions Route to Licensure. And this recognizes credentials from a number of jurisdictions around the world. There are about 14 pages of countries that are included, and it qualifies these physicians for placement in practice on the general independent practice license. I just want to emphasize that this is not at all a lowering of the bar or anything like that. This is us actually assessing where the bar is set and questioning what is it that we need to be looking at to do our assessments. So now we have a cohort of physicians who are moving through the process much more quickly, instead of the way it used to be in Alberta, being redirected to write examinations that are intended for people who are just graduating from medical school. And we have increased our registration numbers as a result.
So this will help it to make it both inclusive and effective, actually. Thank you very much. Renee, building on all of these points, I would like to ask you, how can global accreditation and competency assurance mechanisms build trust in mobile health workforce and institutions to strengthen workforce deployment in underserved regions?
So we look at accreditation as this validation process, and many people, I think, perceive it to be a stamp or a seal of approval where organizations go through a checklist and they have a score. But we approach it very differently. We look at ourselves as strategic partners working with hospitals. So we start at the hospital level. It's very hard to create a top-down approach when you're looking at personnel and how to retain personnel. So if you look at a hospital level and you say, what are some of your pain points? They'll say, well, we have difficulty retaining our doctors. We have difficulty retaining our nurses. How can you help support that? One of the key factors and benefits we've seen of accreditation is that the constant preparation, learning about international best practices, adopting them, implementing them, inspires personnel to want to do better, to stay ahead of the game, to be able to benchmark themselves with others internationally. So the entire process of preparing for and maintaining accreditation is engaging for personnel. It helps organizations attract and retain personnel, and whether it's physicians, nursing, or their administrative staff. Having an international accreditation gives them the confidence that they are truly part of an international global venture. And so then we take that from hospital to health system, from country to country, and we recognize these standards as a way to enhance patient experience, improve clinical outcomes, and continue to scale and grow different areas of clinical expertise, adopt technology, whether it be digital health, remote monitoring, AI, and other types of tools we can use to attract patients from all over the world. But the way that we engage our personnel and give them pride and respect on a day-to-day basis in where they work and how they work will keep them at home. That's the first important piece. The other piece is, I think we need to start young. I think we have to start in school. We are adopting AI training and technology I don't personally give my 5-year-old an iPad yet, but I do know in some countries they're starting at 6 years old to teach them how to leverage AI. Well, let's teach them AI in healthcare. Let's teach them AI in hospitality. Let's teach them specifics about the utilization in AI in areas where we have a gap, and inspire them through some of these industries that are rapidly growing, like medical travel and wellness travel. And I would say the final piece is looking at this integration of accreditation in areas like preventative medicine, longevity, disease reversal. And instead of having those as silos, pull them all together under the same standards, not only for the facilities, but for the personnel and for the programs as they grow them.
Well, thank you for that insight, and I think AI is coming faster than we think. It seems we have not much time, so I'll just one final wrap-up question to all of the panel. What joint actions or commitments can global regulators, accrediting bodies, and academic institutes can take in the next 2 years to close this gap and build a resilient mobile health workforce? And I would like to start off with Dr. Chaudhary, and we'll go to the rest of the
Well, thank you, Dina. I think that's a critical question. None of us, even though we bring a certain level of experience and expertise to the topic, none of us can solve the problems by ourselves, and neither can our organizations. So we will need to rely on organizations like the WHO, which, as you heard Jim mention, has done a lot to give guidance to countries about how to ethically make these decisions. IAMRA also, going back to what Gordon said, their goal is not to tell countries what to do, but to achieve some common ground. I think there are some opportunities to work together to make sure that technology is harnessed in the right way without harming the patient-physician relationship, and also to do it ethically. I think sometimes we get caught in the technology, we get excited about it, but let's not forget at the end of the day, we're talking about a human being who needs to get care, and that care will be helped by machines, but will not replace doctors. Doctors will have a critical role. Machines will help to do it faster and better, but there has to be a collaboration among all the organizations in the world to talk about their lessons learned and their successes so we can all come to a better point.
Thank you, Dr. Chaudhary. David?
Yeah, I think one of the important things to always remember is we don't just do medical education because there's doctors who like to teach. We do medical education to build a workforce to care for those individuals and people around us. We don't just do science because science is cool. We do science to create the next breakthrough technology or develop that next cure, again, for people and for humans. And so I think if we kind of reframe this a little bit and think more about how we can collaborate and work together, as my panelists have said, and potentially design a system that focuses on agreeing upon competency-based medical education. By ensuring that medical education institutions and governments and regulatory agencies around the world come together and try to develop the same set of competencies, then we know when there's mobility amongst healthcare professionals, we're all coming to it from the same footing. And I think that's critically important. And the last thing I'll say is to touch upon what my colleague mentioned. It's not going to be AI versus doctors, or doctors versus AI, or any other innovative technology. It's going to be a partnership and collaboration, and through that, we can also ensure that physicians and all healthcare professionals are able to work at the top of their license and reduce the non-healthcare professional-facing work that has to be done, the paperwork, the busy work, all the elements that are worsening the shortage that we're already facing. Hopefully the use of technology can reduce that burden. And so moving forward, that's another area where partnerships and governance structures can hopefully address and make a positive difference as we look to overcome this impending shortage of physicians.
Thank you. Renee?
I agree with that completely. I mean, 30 to 40% of the time of clinical staff is spent doing administrative work.
Yeah.
So leveraging technology is a key piece a key portion of reducing that and putting other people as well as technology in place to do those non-clinical services. I see accreditation as a trust builder. So we think about how we can help support the health sector. We have to think about how do we build trust with patients as well as the clinicians that are treating those patients. Trust that the environment that they're working for is safe, that it's based on international best practices and standards regarding patient safety, quality, but also patient experience.
Thank you. Dr. Gordon?
Thank you. I'm going to end up echoing a lot of what my colleagues have said, but I think a critical next step is around alignment. And that's alignment around a set of core competencies that defines practice readiness across contexts. I think the other part of it is investment, and that's investment in faculty development, investment in digital verification systems, and investment in equitable partnerships that strengthen education capacity in all regions. I think the goal, again, is around that shared resilience and not specifically redistribution.
So AI, alignment, leveraging technology, building trust, collaborating, and continuing building the capacity of our workforce. It seems like we're about the end of our session. I would like to thank once again all of our panelists for sharing their expertise and knowledge, and I thank the audience and ask them to give them, please, a round of applause as we conclude our session. Thank you very much. Thank you.